everyone. This is Mary Funseth from Superior Health Quality Alliance. And today I would like to welcome you to our second session for chronic disease, structured collaborative session 2, how to screen for and identify patients with CKD. Our presenter today, we will learn with Dr. Orville Campbell. Welcome, Dr. Campbell. Thank you for joining us today.
Thank you very much.
So today we're going to begin with looking at our action plan follow-up, and we will share in the chat our names, titles, our clinic organization, and location. So today's action plan follow-up is to differentiate those patients who are at a high risk of progression of CKD versus those who are not at high risk for progression of CKD. We will have folks chat in a little bit about that in a moment. And today's objectives will be to know what tests to order in order to identify CKD and diagnose and stage CKD based on the testing. So Dr. Campbell, I'll let you begin right here.
All right, thank you very much for inviting me to speak. This is a very important topic because of the morbidity and mortality that's associated with chronic kidney disease, or CKD, as we say. There's also a significant number of dollars attributed to chronic kidney disease. The most dollars are attributed to the individuals, of course, with stage 5 kidney disease, especially the ones who are at stage 5 and need dialysis. Even in the corrections industry, it's extremely expensive. It could be over $3 million to take care of about 40 patients who are in the correctional healthcare space. So this topic is extremely important. So there are a couple of questions we can consider right at the onset. And it's a question that's sometimes is an enigma with individuals taking care of people with CKD. The average person is really afraid of CKD. Some people would rather you tell them that they have had a heart attack or cardiovascular disease, rather than telling them they have kidney disease. There's something frightening about saying you have chronic kidney disease because a lot of patients fear dialysis. So first question to consider, is it appropriate to send a patient to a nephrologist with an estimated GFR or eGFR of 59? Let's consider that. The next question to consider, would you send a patient to a nephrologist with an eGFR or estimated GFR of 80? We'll ponder those and we'll get to the answer a little later on in this presentation. Next slide. How to screen for and identify patients with CKD. Criteria for CKD, we discussed that in the first session. This is a refresher. Abnormalities of kidney structure or function present for greater than 3 months. Number 2, one or both of the following must be present for greater than 3 months. Number 1, markers of kidney damage, 1 or more. That could be an elevated creatinine, elevated BUN, or a GFR less than 60 mils per minute per 1.73 meters square, all right? That's akin to losing almost 40% or more of your kidney function. Why is that GFR less than 60 important? That's when you start to see the wheels of the cart coming off. You start to see primary hyperparathyroidism. What's the difference between primary and secondary? Well, in primary hyperparathyroidism, the gland itself is the one that's out of control and making lots of calcium. So you're usually hypercalcemic. However, in secondary hyperparathyroidism, the issue is the kidney is not functioning correctly. So the calcium levels are low. Well, why are the calcium levels low? Because the kidneys activate vitamin D. Remember, the process starts in the skin, and then the liver partially activates vitamin D. To fully activate vitamin D, the kidney does the final hydroxylation or activation. So therefore, if you have advanced kidney disease, you end up having a lower vitamin D. So lower vitamin D means less calcium being absorbed. So therefore, these patients tend to have a low vitamin D level and a low calcium level. So in reaction, the parathyroid glands increase the production of parathyroid hormones to try and get the calcium up to snuff. So in primary hyperparathyroidism, you see a high PTH, but you see a high calcium. Well, in secondary hyperparathyroidism due to kidney disease, you see a high parathyroid hormone, but a low calcium level to try and get the calcium back to in a great metabolic range. That beats the bones mightily by thinning them, by releasing calcium and phosphorus from the bones to try and get the calcium up to where it should be. But the phosphorus also comes out of the bone. So if you don't have great kidney function to clear that extra phosphorus, well, the phosphorus is high. And that's the basis where we tell patients that they have to minimize their phosphorus intake. But management is going to be a part of a different discussion later on in this collaborative. Next slide, please. In screening or evaluating patients who are at risk for CKD, you start with a very robust history and physical. You start with a patient complaints for the appropriate history. It may be something as simple as, Doc, I just can't seem to get my energy level up. It may be that my bones or what patients find bones or their joints hurt. Could be many things, or I itch a lot. That could be a sign of hyperphosphatemia. Past medical and surgical history. Does the patient have a history of diabetes, hypertension, viral infections, infections of the throat, like a strep throat that tends to be younger people, kids, or a collagen vascular disease, such as lupus. Then we need to look at the social history in detail. Smoking, which can impact the vasculature and cause chronic kidney disease, could be from illicit drugs or legal drugs that are prescribed, or sexual behavior that can lead to hepatitis infection, which can set up chronic infection or acute infection in the kidneys. Then there's the all-important family history. Again, collagen vascular disease such as lupus in some patient population, diabetes, hypertension, and kidney disease, maybe which could be polycystic kidney disease or other kidney diseases. Medications, especially non-steroidal anti-inflammatory drugs, which we shorten to call NSAIDs because it's a mouthful. And you know them as ibuprofen, Advil, Excedrin. Those are some of the common name, Motrin. ACE inhibitors, angiotensin converting enzyme inhibitors, all right? or angiotensin receptor blockers, those are known to lower the pressure within the filtering mechanism of the kidneys and can decrease the pressure in the kidneys and thus decrease the estimated GFR. What's ironic, you'll find out later on in the management of kidney disease, what is actually a potential for injury could be potential for salvation, because sometimes certain things like protein in the urine may actually increase the blood flow to the kidney and increase the pressure within the filtering mechanism, and therefore cause damage and protein spillage. These two sets of medications, the ACE inhibitors and the ARBs, tend to lower the intraglomerular process pressure, or the pressure within the filtering mechanisms, therefore reducing kidney damage in terms of pressure that the kidneys are subjected to, as well as the spilling of protein. So it's a tug and or push or pull situation. Then the review of systems. Take the time to go through the bodily systems and make sure you don't miss important clues to screen in these patients. The physical exam, the BMI, all right? Body mass index is what that stands for. Swelling or edema, pallor, how the lack of color to the skin or the mucous membranes, skin lesions, that could give you hints to collagen vascular disease, such as lupus or other diseases such as sarcoidosis. Next slide, please. Well, what are the risk factors for chronic kidney disease, or CKD? There are numerous, but these are some of the major ones that you will see the bulk of the patients will fall under these categories: diabetes, type 1 and type 2 diabetes. And individuals who develop type 1 diabetes, of course, usually be below the age of 40, and certainly in kids, they run a great risk. These individuals require insulin. The diabetes tend to be more brittle or more difficult to manage than type 2 diabetes, which develops later on, usually after the 40th birthday, and certainly is tied to other factors such as family history, as well as obesity. Hypertension that's not controlled, whether it's controlled or not, it is a risk factor, but if the hypertension is uncontrolled, it's more of a risk factor. And whether you have protein present or not present, that can tell you that the patient is at greater risk. So therefore, you may want to achieve lower targets for individuals experiencing proteinuria or other risk factors. You may want to achieve a lower goal. Obesity, again, tends to be tied with higher creatinine levels, and certainly lower eGFR. So when one is screening, we'll talk about cystatin C a little bit later on in the presentation. That may be appropriate in these individuals. Again, we talked about smoking, family history, abnormal kidney structure such as cysts, including polycystic kidney disease, where the kidneys are just riddled with cysts. Age 60 and older, GFR naturally declines with age. Race, U.S. ethnic minority status, African Americans, Hispanics, Asians, Pacific Islanders, and American Indians. The reason why this is not that GFR declines because of race, because we've just gone to excluded now race out of the calculation of GFR. It's been accepted by the American Society of Nephrology. So that's been sort of kicked to the curb, or should be kicked to the curb. But this is more an issue of socioeconomics, access to healthcare, patients on getting healthcare that is not culturally competent, pharmacy deserts, food deserts. So it's more so socioeconomic and access to healthcare than it is being under one of those designations. The inappropriate use of non-steroidal anti-inflammatory drugs, again, or NSAIDs. One should not go beyond the duration in using these drugs, which can hurt the filtering mechanisms of the kidneys. It can also lower the eGFR and subject the kidneys to damage. History of acute kidney injury for whatever reason, and one may end up into the hospital, into the doctor's office with acute kidney injury. And depending on the severity of the injury, an acute injury can become long-standing chronic kidney disease. I'll pause here. Are there any questions in the chat that's relevant to what we've covered so far? If so, I'll be happy to answer those questions. If not, I'll move on.
There's no chat. There's nothing in the chat right now, but
Okay.
we do have participants on that may have a question if you want to ask any.
Sure. Mm-hmm. And you can ask those questions at any time, because the whole point is to relay great information to improve clinical outcomes of patients, not that I need to get to through the material in a certain amount of time. So don't feel pressured not to ask or to interrupt. All right, next slide. These are some general recommendations by the Mayo Clinic in the prevention of CKD. Do follow the instructions on the over-the-counter medications. When using non-prescription pain relievers such as aspirin, ibuprofen, and ibuprofen can go under the trade names of Advil, Motrin, etc., and even acetaminophen, Tylenol, ensure that you follow those prescription or those prescribing guidelines. Too much Tylenol can cause kidney damage. A lot of people don't realize that. Tylenol overdose can be associated with acute kidney injury. Follow the instructions on the package, insert, the labels. Taking too many pain relievers for a long time could lead to acute and or chronic kidney damage. Maintain a healthy weight. If you're a healthy weight or BMI, maintain it by being physically active. Physically active doesn't necessarily mean you have to go to a gym, get a gym membership. Walking 20 to 30 minutes a day is great exercise. Swimming and walking are great exercise. If you do have joint problems, pool aerobics or pool exercise, if you don't want to do a formal aerobics class, is a great way to stay fit without the constant pounding and trauma to the joints. That is an excellent way to have fun and to get some exercise in at least 20 to 30 minutes a day. If you do need to lose weight, speak with your primary care provider about strategies for healthy weight loss. Don't smoke. Smoking can damage your kidneys and make existing kidney damage even worse. If you're a smoker, speak with your provider, primary care health provider, about approaches and strategies for quitting. Support groups are an excellent idea. Counseling and medications as well can help all to stop smoking. manage your medical condition with your primary health providers and specialists if you require specialty care. If you have diseases or conditions that increase that risk of kidney disease, work with those providers to control them. Ask your providers about tests to look for signs of kidney damage. Again, assess that family history risk and your risk, such as hypertension and diabetes, etc. Next slide, please.
Before we move on to the next slide, I do have a question in the chat. This is from Daniel, and when to stop ACE inhibitors?
I usually recommend that if you start an ACE inhibitor or an ARB or ARB, that you do check within 7 days whether someone has a chronic kidney disease or not. Check within 7 days of starting an ACE and an ARB, to see the rise of the creatinine. Now, let me say this. I expect the creatinine to have some bump because those drugs work by decreasing the intraglomerular pressure. So GFR or eGFR will decrease. So when it's usually sustained above 30%, I would either stop the drug or decrease the drug and recheck within 3 to 7 days. That's been a great approach. Again, expect for the eGFR and to go down and the creatinine to go up. That's what those drugs do. So don't automatically stop it because there's a bump. And in many cases, the creatinine will return to normal, and so will the eGFR, or to baseline, whatever that patient's baseline is. All right? Hopefully I answered that question. If I did not, just ask a clarifying question. I'll be happy to address that. All right.
Thanks, Dr. Campbell. No clarifying question yet in the chat. And I apologize, Dr. Berg. Do you have any other questions in that area?
No, I don't, but it's been a great talk so far. Thank you.
Great.
Thank you. All right.
Okay, we'll
Next
keep
slide.
going.
All right, let's talk about what do we do to screen patients. At Emory, we used to say the gold is in the urine. All right, and that's where the money is, really. It can tell you so many different things. The first thing we need to do is look at the physical color and the appearance of the urine. It should look like that urine to your far left. Clear, straw-colored, even preferably like cheap lemonade that you can see through, all right? And it tends to be colorless or a pale yellow. As we change colors, it can be an indicator of a disease process or abnormal hydration status. Dark yellow, it's usually mean the urine is concentrated. Things like bilirubin in the urine, which will make it yellow, and other chemicals in the urine or waste products in the urine will discolor it. Green may indicate a bacterial infection, and the different colors, yellow, green, bilirubin, red could mean blood, that there's actually blood from the bladder, blood upstream in the kidneys, or it could mean myoglobin, which comes from damaged muscle cells, such as going to the gym and not hydrating, and you do have rhabdomyolysis, or any causes of rhabdomyolysis could be as simple and ominous as drinking too many energy drinks. We've seen college kids have a lot of destruction of their muscles from energy drinks due to caffeine. And brown and black could mean methemoglobin and other rare things in the urine. So we won't go into that. Again, you can see very good if the urine is yellow, clear to pale yellow or straw color. And as it gets darker, it can indicate severe dehydration or the presence of something that should not be in the urine, such as blood, all right? Is the urine foamy or soap suddy? And that could indicate the presence of protein, which should not be in the urine in significant quantities. All righty, next slide. The dipstick. After the appearance, then you need to assess it for specific gravity, as well as 9 substances you see listed there, such as glucose, which could indicate diabetes, uncontrolled diabetes, or it could be the presence of eating substantial amounts of sugar that just spills over the limits, sugar filtration limits of glucose. Bilirubin, which could indicate liver disease. Ketones, of course, could be a key to diabetic ketoacidosis. Specific gravity gives an indication to the concentration of the urine. pH can give you some great indication of what's going on in case of certain poisonings or metabolic states. Of course, protein is very common in kidney damage that is chronic, and nitrite and leukocyte esterase can give you some indication about bacteria activity in the urine and infection. And to the right, we won't go into that, but that's like the guide that you use to interpret the colors after you dip. So this is actually a chemical assessment for 9 substances and the specific gravity. Next slide. The microscopic, often forgotten, very often forgotten. Usually urinalysis is ordered, a dipstick, but a complete urinalysis with sediment analysis, which means we collect the specimen, it's spun in a centrifuge, and the little button that's at the bottom is left in the bottom of the test tube. The liquid is decanted, and then that button or the sediment is placed under a microscope, and it will analyze the type of cells, casts, crystals, or other inclusions such as mucus and bacteria. If someone has an acute kidney injury, which could be a setup for CKD, you may find different types of casts to tell you that, what it is. More long-standing in chronic kidney disease will have different types of casts. Can have cellular casts, such as red blood cell casts, which could be a sign of acute infection, could be a sign of a collagen vascular disease in its acute state, such as lupus. So the sediment is often overlooked, but again, there's gold in the urine and the sediment. Next slide, please. All right, the spot urine for albumin to creatinine ratio, ACR to detect albuminuria, spot urine protein to creatinine ratio, more general, all right? And both of those you can order, actually order either. There was a study done that I'm trying to write. It's it's a comparison of association of urine protein creatinine ratio versus albumin creatinine ratio with complications of CKD. This was a cross-sectional analysis published in the American Journal of Kidney Disease in 2013 that shows that you pretty much get the same data. They're very comparable, whichever one that you do use. So again, the urine analysis followed by the spot urine albumin to creatinine ratio, or the ACR, and the spot urine protein to creatinine ratio, followed by serum creatinine and the estimated GFR, or glomerular filtration rate. Next slide, please. Urinalysis interpretation, again, this is an example of a disease. Infection, bacteria should be absent, but if it's present in any amount, that is abnormal. Leukocyte esterase is positive with the presence of white blood cells in the urine. Significant amount is usually greater than 10. A red blood cell, you should not see any less than 5. Hematuria can be present, in this case, infection, infection, or it could be in a collagen vascular disease, such as lupus. pH, increase in urea splitting organism. Next slide, please. Blood work. This is the basic blood work, CBC, complete blood count. If needed, you may add a platelet count to it. Basic metabolic panel, which includes sodium, potassium, BUN, creatinine, chloride, CO2, etc., and with an estimated GFR. Albumin, if it's low, may indicate urinary protein loss or malnutrition. Lipid panel can give an indication of chronic kidney disease because it is a risk factor for cardiovascular disease. Cystatin combined with creatinine can also help in those patients who have a BMI greater than or equal to 35, or in obese women. The cystatin is actually filtered, but it's not secreted and it's absorbed. So it's a great factor that can be used for individuals who tend to have a lower GFR because of obesity, but may not actually have chronic kidney disease. Cystatin C, again, is filtered and it's reabsorbed, but it is not secreted. Next slide. Screening for CKD, again, more advanced blood work. You can see it right there. The so-called serum protein electrophoresis, or SPEP, which could be an indicator for myeloma or other similar diseases. ANA, double-stranded DNA, great screens for collagen vascular disease, such as lupus, scleroderma, etc. Complement levels, blood complement levels tend to be low in infectious or inflammatory disease processes of the kidney. Viral diseases such as Hep B, Hep C, HIV, and syphilis can also impact the kidneys in a chronic way. Next slide. As we talked about in the previous presentation, session 1, the GFR, you can stage them anywhere from G1 to G5. And as this graphic shows, as albuminuria increases and GFR decline, so does the impact on the kidneys. So the higher the GFR, the lower the protein spillage, ideally none, the less you will tend to progress in terms of losing kidney function. Next slide, please. Screening for CKD continued. Kidney ultrasound, assessing for size, the cortical thickness, which is the outer rim of the kidneys, which gives you a good indication of kidney health, and the echogenicity, which is the best correlation to creatinine, is that fuzzy white appearance of the kidney that shows or indicates disease and or scarring. Next slide. Track the eGFR. Again, track it versus time. Make it a part of the chart. Whether you use CKD epi versus MDRD, modification of diet and renal disease study equation. Don't want to get into that. Just use the equation. Let's not add race into it. That's been done away with because, again, it overestimates the GFR in vulnerable population and can impact their ability to be transplanted in a timely manner and other issues as well. Next slide. Again, how often should patients be screened for CKD? Usually annually in most diseases, including someone with a family history, obesity, smoking, hypertension, and diabetes. Of course, more frequently if they do have CKD. Next slide, please. This will tie back to our poll question. When do you refer to a nephrologist? Well, number one, anytime a primary healthcare provider is uncomfortable in taking care of any chronic kidney disease at any stage, it is better to refer and to make sure the patient is taken care of. GFR less than 60, strong consideration because of secondary hyperparathyroidism beginning. Again, we ask that question, would you refer someone with a GFR less than 60? Again, that's when the wheels start to come off. So yes, if you are uncomfortable or not skilled in taking care of the complication, that may be a great time to refer. Mandatory at a GFR less than 30. All individuals should be. And I asked the question, should you refer with a GFR of 80? Could be, it depends on where you're starting. You could have started with a GFR of 120. If you're exceeding 5 milliliters per minute per year and or a sharp and sustained decline at 80, then yes, because that's a rapid loss of kidney function. So it's not only the absolute loss, but the rate of the loss. Persistent urine albumin creatinine ratio greater than 300 milligrams per gram, or urine protein to creatinine ratio greater than 500 milligrams per gram. Next slide. Questions?
We don't have any questions in chat right now, but if our participants have any questions, you can put them in chat, or you can just ask Dr. Campbell.
All right, next slide.
Okay.
A little bit of homework we're going to do.
Yeah.
Slide, action planning. Action plan or homework for a more unsavory term. Pick 5 random patients with diabetes and no formal diagnosis of chronic kidney disease or CKD. Calculate their eGFR using an eGFR calculator minus race and see what you get. Just do your own research project and see if those individuals have been missed. It'd be very unusual to not find some kidney disease in a patient with diabetes with no formal diagnosis of CKD. So that's our action plan or homework for next time.
So everyone, thank you, Dr. Campbell. This has been really a lot of great information today, and really I'd like to have everyone open up their mics at this point. Perhaps we can have a bit of a discussion and or entertain some more questions. Any questions, first of all, around the action plan? Does this seem doable for folks?
Oh, yes.
Okay.
And can you comment on, I know they're getting rid of creatinine. They're going to combine the GFRs for non-black, black, and they're going to come out with a new way of calculating all this in the next year. And that's what I heard in the New England Journal, reading about it. I don't know if common knowledge, I don't know if it's common knowledge. How is this going to change our care of the patient?
It will, because we'll find that we have been overestimating the GFR of some vulnerable populations, such as African-American patients. And why is that important? It can be, from a cultural competence point of view in terms of healthcare management, be discriminatory, because especially in diabetics, as you lose GFR, and coming down to that 20 range, where you can just simply develop the need for dialysis without rhyme or reason for whatever reason. And if you're overestimating, those individuals could already be below 20 and should be having those talks about certainly transplantation, especially living-related donor. But because they're overestimated with no really solid evidence of such, then they would not be referred. So it would change the management based on assigning them to the correct stage. Someone who may be at 70 may actually be at 59. And that's a different discussion from stage 2 to stage 3. So that's how it will change the management. The calculators online, you can find them, and you can deselect race as part of that. You can do statin C, GFR, and put those in the calculators. But again, cystatin C is not available in every institution or organization. Any other questions?
All right.
Thank you, everyone. Again, thank you for inviting me for a very good discussion on screening for CKD, especially early CKD, and identifying those patients who are at risk for CKD.
We really appreciate it. We would like to ask, since we're a little bit further ahead right now, how did things go in the activity for the participants that you may have worked on last week? The activity was to differentiate those patients who are at high risk of progression of CKD versus those who are not at high risk for progression of CKD. And if you weren't able to work on that, that's perfectly all right. But that would be something to also consider as you work with your team. So hearing nothing at this moment, I'd also like to bring your attention to our schedule and where we started and where we're going. We are now almost at the end of our second session, and we are looking forward to our next session, which is Wednesday, November 17th, same time, noon to 1 p.m. Central Standard Time, or otherwise known as 1 to 2 p.m. Eastern Standard Time. And the topic area this coming week will be management of early stage CKD. And this will be including information on medications. We also have for you the algorithms in prep for next week. So I'm just going to stop sharing just for a moment. And we'll bring those up. Apologize, Jerry, I don't have them. I'm not seeing them. And I had them all handy. So are you able to share those?
Just see if I can find them quick, Mary. Otherwise, and they are in preparation for next week. So I'll be sending out the slides and the recordings from today's session. And I can send the algorithms out in that email too, so that everybody can have a chance to look at them prior to the session next week. That might be just as easy because we were just going to pull them up. We weren't really going to discuss them yet today. So
Right.
that might be
And
the
I
better
think
way
it's
to do it.
probably more relevant for session 3 anyway. So,
Okay. All right, then I will not share those. Any lasting questions?
What an excellent presentation. Thank you.
thank you. Thank you.
Okay. Well, this concludes our session for today. And we appreciate everyone for their attendance, and we look forward to questions in between sessions as well. So don't hesitate to let us know if you have some questions.